So today it's my pleasure to introduce Matt Jordan. Matt did his bachelor and master's degrees here in kinesiology at the University of Calgary. He's now very close to defending his PhD under the supervision of Dr. Walter Herzog. Matt's research is very focused on assessing and helping elite athletes in their return to sport after injury, and he's well regarded in this field. His expertise is reflected with his consultation work with Olympic athletes through Alpine Canada, the Canadian Sport Institute, as well as his research done at Canada Olympic Park and his attendance at 4 different Winter Olympic Games. Now, when Matt isn't helping athletes return to sport, he keeps active through cross-country skiing, martial arts, and chasing his kids.
Yeah.
So today, Matt's going to be presenting his doctoral work in a presentation titled Associated Pathology and Lower Limb Asymmetries in ACL Reconstructed Elite Ski Racers. Are you ready?
Thank you. Yeah, so it's great to be here, and I hope to, over the next 30 to 40 minutes, just give some highlights and an overview of what I've been doing in the past 4 years towards my doctoral research, looking at return to sport screening with ACL reconstructed ski racers, particularly around neuromuscular assessments. So kind of 3 main objectives for me today. The first is to give a rationale for why I think this research is important. Second is to look back over 3 research projects that I've completed to give sort of a highlight reel of what I accomplished. And then at the end, in the last sort of 20 minutes, I hope to present some new data on a project that was recently completed looking at the associated pathology and recovery after ACL injury in elite alpine ski racers. So ski racing is a high-risk sport. The knee is the most commonly injured body part, and the most specific diagnosis is ACL tears. Injuries often happen like the video you're watching on the screen. Skiers are out of balance. They land in funny positions or get caught in a turn. There's high energy transmission to the knee joint that stems from the equipment, skis, the boots, the unpredictable terrain. After ACL injury, a big concern is preventing a second ACL injury because it's a high prevalence in ski racing. They often happen like the video you're watching, which is a bit dramatic to see. It's a ski racer coming back. He's about 10 months post-surgery, cleared to go back on snow, rounding a turn, and then he loses his ski as a result of some issues with his left side, which is his ACL reconstructed limb. And at the bottom, you can see him clutching his contralateral knee. He suffered a re-injury to the opposite knee. Happens very frequently at the top level. Ski racers who have ACL reconstruction, they estimate about 50% will have a re-injury. So what this highlights is the importance for return to sport screening, neuromuscular assessments to be able to evaluate these athletes to make sure that they're fit to get back to this high-risk sport. It's tough, you know, after an injury, athletes are motivated to get back. Coaches want them to get back. The surgeons have a lot of confidence in their skills. Everybody is oftentimes very focused on how do we get them back and how quickly can we get them back. But one of the concerns in the literature is that there seems to be an over-reliance on subjective measures. So not really assessing anything, just sort of, you know, clearing them based on what the practitioners just might be seeing. And I'm going to give you a case study example why that might be a concern. This is a 17-year-old female ski racer whose mom had heard I was doing research in this area, and she asked if I would test her, and I was happy to oblige. She came to me. I asked her how she was doing. She said, "I feel great. You know, my knee feels good. My physio's happy. My strength coach is happy, and I'm just really excited to get back on snow." So I assessed her, and I'll talk more about my methods in a couple of slides. But you can see I have a force plate under each of her legs, so on her left foot and her right foot. She's a right side ACL. And so with my setup, I can measure the ground reaction force simultaneously from the left and right limb during jumping or squatting or what have you. So in this case, I have her doing a vertical jump. So remember, she feels great. In the bottom phase of the jump, this is the deceleration phase, her asymmetry was 22.5%. In the ascent phase, where she's coming up off the plates, her asymmetry is 17.5%. And you can see now the asymmetry. You don't have to measure this to be able to see that something is asymmetrical in how she's jumping. So what she's actually doing is slingshotting off towards her right side, her ACL reconstructed limb, and then she lands in what many experts would call as a high-risk position for a re-injury. So it's just a very interesting example of how you can feel great. Everyone can be very optimistic about you getting back, but sometimes it's better not to feel, but to measure. something, and I think that's sort of the cornerstone of what my research has been about. It's not only about getting them back on snow. When you have ACL injury, we often hear ACL injury, but there's other things that happen. You know, the meniscal tears can occur, articular cartilage lesions, multi-ligament injuries. And what we know is that young athletes who sustain an ACL injury, they're at high risk for developing early onset of knee joint osteoarthritis later in life. This radiograph is actually from a ski racer who's now in his 30s. And he called them his dark days, coming back after injury where he could no longer play with his kids because of the development of knee joint osteoarthritis. So here he had to go back in for a very specialized surgery to remove bone and realign his tibia and his femur to be able to unload his knee joint. So that was probably at the age of 35 or 36. So I guess the question here is it's not only about the short-term outcomes, but how do these athletes fare over the next decade or 15 or 20 years in their life as they head down the road into post-sport life. So that's kind of an overview of why I think this research is important. I want to talk a little bit about how I've approached evaluating functional asymmetries, which is sort of some of the methodology behind what we've been doing. You saw in that picture, I evaluate athletes by having them perform vertical jumps using a dual force plate system. So I have a force plate placed under each foot. It's a really simple way to evaluate functional asymmetries in a high performance sport environment. So we can run this test in 10 or 15 minutes, even less sometimes, just because of the fact that it's a quick test and we can we can capture that functional asymmetry. So this is our setup for evaluating it. And you can see if you had a ski racer with an ACL reconstruction, you could capture the asymmetry by comparing the right leg to the left leg. One of the challenges I had when I started down this road is that the asymmetries were not intuitive. I often found that in a single jump, the asymmetry would shift between limbs in an ACL reconstructed athlete. So I had a challenge here, and you can see this on this representative force time tracing of an ACL reconstructed ski racer. So we've got the ground right reaction force on the vertical axis and time along the X, and this is a single counter movement jump. But you can see just visually looking at this that the ACL reconstructed limb early in the jump is actually generating a higher force. And so, if you were just looking at the instant of the peak vertical ground reaction force, which a lot of people do, you might incorrectly conclude that actually it's the ACL reconstructed limb that seems more recovered or stronger than the opposite limb. But when you look later in the jump, the asymmetry actually shifts the way that you would expect. It's now the non-injured limb that's generating a bigger impulse. So this was a bit of a challenge for me to be able to figure out how am I going to capture this asymmetry that may shift between limbs over a vertical jump. So what we did with a counter movement jump, which is a jump where you've got hands on the hips and you start standing, it would be a jump like you would execute if you just were doing one normally, and the athlete drops down and jumps up. So you have a pronounced deceleration phase in the bottom of the movement, and then you have a concentric phase where the athlete is coming back up into the air. So what I did was to take the vertical ground reaction force, solve for acceleration, integrate acceleration with respect to time to obtain the velocity of the body center of mass. And then using the velocity of the body center of mass, I can identify the unloading phase where the athlete's dropping down into the bottom position, the eccentric deceleration phase in yellow, and in green, the concentric phase. So now what I can do is sort of identify these different phases in the vertical jump. So from here, I would integrate over that time interval, so over that jump phase, to obtain the vertical ground reaction force impulse. And I would do that separately for the contralateral limb and the ACL reconstructed limb, because we have the two force plates going. And then we just used a very simple asymmetry index where we took the contralateral limb minus the ACL reconstructed limb divided by either the max of the left or the right, whichever one was higher, times 100, so that our asymmetry index, if it was a positive number, it would indicate contralateral limb dominance. If it was a negative number, it would indicate ACL reconstructed limb dominance. And if it was a value of 0%, it would be, symmetry. There's a second type of jump that we use, and it's called a squat jump. And a squat jump is uniquely different than a counter movement jump because here, you'll see in the video, he drops down to a starting position and holds that starting position for 4 seconds and then is instructed to jump. So it's a purely concentric only movement. And you can see that in the ground reaction force. There's no unloading phase, deceleration phase. It's a pure positive slope as the athlete comes up and off of the force plates. I've used stick figures throughout my presentation to hopefully orient you to the jumps because sometimes it can be confusing. But this is the second type of jump that we do. This is another representative force time tracing from an ACL reconstructed athlete. And you can see the same challenge, is that early in the jump phase, you actually see that it's the ACL reconstructed limb generating a higher force. And later in the jump phase, then the asymmetry goes like you would think. So using a similar approach with the squat jump, we looked at the asymmetry in the early takeoff phase and the asymmetry in the late takeoff phase of the squat jump. So 2 types of jumps and 2 phases of interest for each jump. So the question that I wanted to look at first was looking at ACL reconstructed elite alpine ski racers who are now back racing or back to sport. Do functional asymmetries and neuromuscular deficits persist despite them being back into full racing? So that was the first question that we looked at. We evaluated in the first study 9 ACL reconstructed elite alpine ski racers and 9 uninjured controls. And on average, the ACL reconstructed group was 2 years post-surgery. So these were skiers now kind of back at it, racing, doing their thing. And we compared the asymmetries in this ACL reconstructed group to this non-injured group of elite alpine racers. So looking at the eccentric deceleration phase, we didn't find a group difference. There was not a statistically significant difference. But what I want to mention here is that we had those ACL reconstructed skiers with very large asymmetries that just went in the opposite direction. So it was actually the ACL reconstructed limb that was generating higher impulse, right? Whereas others went like you thought. But when you calculated a group mean, it was kind of a wash. And so it brought that average down. So we didn't find a statistically significant difference, but you still saw skiers in that group, in the ACL reconstructed group, with quite high asymmetry. Looking at the concentric phase, so this is where they're coming up and off the plates in the counter movement jump, we found a significantly higher functional asymmetry in the ACL reconstructed group compared to the control group, and also in the late takeoff phase of the squat jump. The other thing I want to draw your attention to, because it'll be relevant later, is just the relative symmetry of an elite alpine racer that has not had an ACL injury, which makes sense. They do bidirectional high force turning, and they're very good athletes. And because the sport is bidirectional, typically you don't see them with these huge asymmetries like you see in some of the other sports that you might be dealing with. In addition to looking at functional asymmetry, in this particular study, we looked at lower limb muscle mass with DEXA scanning. And we found a small but significant difference in asymmetry between the 2 groups in terms of the lower limb muscle mass. Next, we wanted to look at the amount of variation that was explained in the functional asymmetries by the asymmetry in muscle mass. And what you can see for the counter movement jump, concentric phase, and the late phase of the squat jump, the late takeoff phase, is that the variation explained in functional asymmetry is less than 50% in terms of the asymmetry in leg muscle mass, which brings up other questions like, the ability to activate muscles, or maybe there's guarding, like extra co-contraction from the hamstrings, and maybe these are contributing to functional asymmetry in some way. The video you saw of the skier who went for the tumble and injured the contralateral limb, I just want to highlight that was him. So in the post-injury period, he suffered that injury. And it was interesting to note that skier had the highest functional asymmetry out of all of the skiers that we tested in all of the different jump phases. So that's just a note that we observed in the post-injury period. So next study that we looked at was quadriceps and hamstring strength post-ACL reconstruction. We had 21 non-injured skiers, 8 with ACL reconstruction. They performed a maximal isometric voluntary contraction of knee extension and knee flexion. And we looked at maximal strength and the rate of force development, but I'm only going to touch on the maximal strength data. Consistent with our functional asymmetry data, we found that injured limb had significant hamstring deficits and quadricep strength deficits compared to the contralateral limb and also to the limb average of non-injured alpine ski racers. It's not, when you think about the ACL injury, you start thinking, oh yeah, got to rehabilitate the quadriceps, but there's more to it than just the actual injury itself. In fact, one of the surgical procedures, and I was amazed when I actually watched the surgery and saw what they did, is they actually completely remove the semitendinosus tendon for reconstructing the ACL in one of the preferred surgical procedures. This will tie back into the presentation later. So you can imagine that completely stripping this tendon also has a huge implication on hamstring strength, which is critical for a ski racer. And the reason is they get themselves into deep angles of knee flexion. The ACL is resisting anterior translation of the tibia on a fixed femur, so resisting that anterior shear force. And especially in deeper angles of knee flexion, the hamstrings are in a unique position to exert posterior shear force on the tibia and actually stabilize or help stabilize those forces and obviously, act as a synergist with the ACL. So the hamstrings are a really critical part of the surgical procedure potentially in terms of a recovery for an alpine ski racer. A lot of the testing that we had done this far was all rested state. So, you bring them in, they do 5 jumps, you measure their asymmetry. But what we know in ski racing is that they tend to not hurt themselves when they're rested. Injuries often happen at the end of the race, presumably when factors stemming from fatigue are present. So this introduces a new element of looking at functional asymmetries and evaluating these athletes, because you want to capture them not only in a rested state, but you also want to see how they deal with asymmetries and whatnot when they're fatigued. And in the literature, there's also been a highlight around the importance of that hamstring quadricep coactivity, and showing that with fatigue, that this hamstring quadricep preparatory activity can be impaired with fatigue. So that's kind of 2 angles now, as we've got the asymmetry, and we've also got the coactivity between the hamstrings and quadriceps in terms of potential factors that are important for a ski racer coming back from injury. So what we did is we have a test that now takes our squat jump and extends it over 80 seconds. So the athlete does 1 jump every 4 seconds for 80 seconds. You can see this athlete is in the final couple of jumps of her test, and just by her face, you can see that it's not a maximal exercise test, but they're definitely tired at the end. And from here, we're capturing, the force data, the EMG data, which is synchronized, and now we're able to sort of look at the EMG data in relation to the force plate data. So our test, we started off sort of looking at 5 jumps. We extend this out to 20 jumps, 1 jump every 4 seconds for 80 seconds. Now we can look at their functional asymmetry in both a rested state and an acutely fatigued state. And we can look at the hamstring quadricep activity levels at takeoff and also just in that instant before they touch down on the force plates, which is called preparatory muscle activity, which is important for, pre-activating in that just before you touch down in that landing phase. And we can look at that both when they're rested and also when they're acutely fatigued. So again, one of the highlights that comes out of this research this project that I think I wanted to share was that when we looked at the quadricep activity at takeoff in the ACL Reconstructed group, what we found was that there was a lower MBC normalized quadricep muscle activity in the affected limb, so the ACL Reconstructed limb, comparatively to the contralateral limb. So that was one of the findings that came out of that particular study. We also found, interestingly, that quadricep muscle activity went up with fatigue for all limb conditions. So the control limb, the ACL Reconstructed limb, and the contralateral limb showed increased quadricep muscle activity with fatigue in that pre-landing phase. And again, that's one of the factors that's been associated in other athlete populations with a high risk for ACL injury. Associated with this increase in quadricep activity was a decrease in hamstring activity. So quadricep activity goes up, hamstring activity goes down in that pre-landing phase. And again, the tie back is potentially, in other athlete populations, that's something that's been presented as an ACL injury risk factor. What I want to note about this group of ACL reconstructed skiers who are on average 3 years post-surgery is it was very interesting that ACL reconstructed limb actually displayed lower quadricep activity and higher hamstring activity in that pre-landing phase. So it's almost like there was an adaptation of some sort where they're, engaging the hamstrings muscles more in that pre-landing phase to be able to potentially offload the ACL. I'm speculating there. I don't know that for sure, but that was one of the, hunches we had about why we were seeing what we were seeing. So looking at that research, those first 3 projects, the main takeaway conclusion that I had was that neuromuscular deficits are persistent in ACL reconstructed ski racers who've returned to sport. So you hear about it in the media all the time. 4 months the NFL football player got back into playing. We've got athletes especially have this expectation that they should be back ready to go at 12 months at the absolute latest. But what we're seeing is that these deficits can really persist over time and are obviously present even though they're back racing and doing whatever they're doing, and obviously of importance given the high prevalence of re-injury. So the final project was really now around, okay, we know these neuromuscular deficits are there. We also know that, you say ACL injury, but it's not just an ACL injury. There's all kinds of other stuff that goes on, particularly to the articular cartilage and to the menisci. So what we wanted to do in this final project was to look at the associated pathology and the lower limb asymmetries in ski racers, and particularly in the recovery of lower limb asymmetries as skiers come back after ACL injury. So there's quite a bit of data that I could talk about here, but just in spirit of keeping this in sort of time with the seminar, what I'm going to focus on is the pattern of injury at the time of primary ACL reconstruction. So what occurred at that time. We also looked at revisions and bilateral ruptures, which I'm not going to touch upon in this presentation. We're going to look at meniscal tears, particularly whether it was the medial or lateral meniscus that was injured, and then the type of tear. It could be a complex tear, a radial tear, a peripheral tear. This is how the surgeons classify meniscal injuries. And then we're going to look at chondral lesions and also the progression in chondral lesions. And I'll explain how we did that. But the chondral lesions are graded from 1 to 4, with 4 being the most severe kind of exposed bone, and obviously the one where it's sort of the most severe on that spectrum. We also did functional asymmetry testing, and I'm not going to present the squat jump data. I'll just focus on the counter movement jump data for the presentation. So the research question built out like this. When you look at the literature, it seems like there's distinct ACL injury patterns in skiers based on, when you compare to other sports like, soccer or basketball. And we also know that associated pathology is a really important determinant of outcome. So whether they have meniscal injuries or chondral lesions. There's also been more discussion in the literature recently and also some data showing that despite getting back to sport, that these deficits persist. So the argument has been made that, is it really more of a 2-year timeline, not a 12-month return to sport, but should there be a recommendation of 2 years to get back to sport? And so in this context, the aim was to look at, what is the associated pathology at the time of primary ACL reconstruction, and what does the functional recovery look like in a group of alpine ski racers? And this was undertaken more like an exploratory type project, and I'll explain why in a couple of slides. So purpose number 1, look at the associated pathology at the time of primary ACL reconstruction. Number 2, look at the potential progression in injury. And number 3, look at the time course recovery in the vertical jump interlimb functional asymmetry following primary ACL reconstruction. What we did is we accessed the database where the skiers had done their fitness testing on a yearly basis. And we found 137 ski racers between the years of 2000 and 2015. Then sat down with the physiotherapists, the surgeons, the team physicians, the coaches, and we went through the list to identify who had had an ACL injury in that group. And we identified 39 subjects. They were contacted. 32 provided informed consent. They completed a questionnaire for a total of 39 knees. So there was 32 subjects, 7 who had bilateral ACL injuries. And then from there, we were able to obtain 28 knees that had primary surgery or primary ACL reconstruction operative reports. So at the time of that first ACL injury, we had 14 knees that had subsequent surgeries for meniscal tears or chondral lesions. And we had 6 operative reports for ACL revision. So basically 28 that characterize that first injury, and then 20 operative reports that look at what happened down the road after they come back in for whatever might be going on to get their knee looked at from a surgical perspective. So the questionnaire data we asked of the athletes were around kind of variables like, when did your ACL injury happen? Who did the surgery? What graft type did they use? And when did you have future surgeries? So we asked some high-level questions about when and sort of things that we felt that the skiers could remember well. We then obtained these operative reports from 6 Canadian orthopedic surgeons. The data, we sat down with a medical professional who was expert in this area, who helped us look at the actual operative reports to code the pattern of injury. This data was then transferred into Excel. We then had a second researcher who sat down and independently went through the operative reports and looked through the operative reports, made a recording of what was found so that we could compare for accuracy. And in any case that we had a discrepancy where something was unclear or didn't seem right, we were able to contact the surgeon to get a follow-up to clarification to find out what had gone on. And for all of our statistical testing, we looked at a chi-square test of proportions to compare these injury subgroups. So as a subset to this, 17 of the skiers, so 17 of the 32, had done functional asymmetry testing at various time points after their ACL injury. So it was anywhere from 138 days to 12 years. Not one subject would have given data through that entire time period. So we have subjects that kind of come in early on, some that are coming in late on, but we took this data and basically what we obtained from them was asymmetry testing where they performed 5 counter movement jumps and 5 squat jumps, used an average asymmetry, and on average, each subject had contributed 3.7 testing sessions for our data. And we then used a nonlinear mixed model to look at the effects of time or days since surgery on functional asymmetry. So now for the results. Looking at the associated pathology at the time of primary ACL reconstruction, first of all, I want to highlight there was no real sense of more right side injuries or left side injuries. And also coming back to my little point about the hamstrings tendon is the majority of the surgical procedures involved the semitendinosus autograft. So that seems to be the surgical procedure of choice for ski racers during that 15-year period. 32% had a multi-ligament injury. And then looking at our chondral injuries, 54% at the time of primary ACL reconstruction had some sort of a chondral injury. 73% occurred in the lateral compartment. There were 61% of the knees with meniscal tears, and 82% of those were complex in nature. So complex tears means that there's multi-directional tears in that meniscus. So it could be, a vertical tear and a horizontal tear, and basically the surgeon's having to do, some, serious repair or resection on that meniscus. Looking at the progression in chondral lesions. So now this is a time point where the skiers have gone off, and now we're looking at these future operative reports to see how these articular cartilage injuries have progressed. 38% had some sort of future meniscus or chondral surgery, and that occurred on average at 4.7 years after the ACL reconstruction, so that first ACL reconstruction. At the time, from the 20 operative reports that we were able to obtain, 80% had worsening chondral lesions. So 80% of those skiers had some sort of progression in an articular cartilage injury, and at this point in time, 63% are now grade 3 or 4. So they've now progressed to the most severe level of chondral lesion. This is the data looking at the functional recovery after primary ACL reconstruction. You'll remember from my stick figures, this is the eccentric deceleration phase and the concentric phase of the counter movement jump. We've got the asymmetry index along the y-axis and the days since surgery along the x. And essentially, what it's showing is the recovery on average for the group in functional asymmetry and the variance that is explained in the days since surgery in terms of the recovery in functional asymmetry. What's interesting to note is that if you look back to the slide that I showed at the beginning that shows the relative high symmetry of a non-injured alpine ski racing group, it took on average 1.9 years for functional asymmetry to reach values that would be comparable to the group of non-injured ski racers. Now, I'm not saying that that's where you let them go back to snow, but that's just what we found. So as a discussion point, 82% of our skiers sustained some sort of combined injury versus 56% to 72% that's reported in other athlete populations. 82% of the meniscal tears were complex in nature, comparatively to 8% in a non-elite alpine skiing population. At follow-up surgery, those 20 operative reports, 80% of the chondral lesions had worsened, and 63% of the knees were now grade 3 or 4 in terms of their severity of their ACL or their articular cartilage injury. In other high-risk sports in general, the general sense is that return to sport neuromuscular monitoring is absolutely key to safeguard athletes against re-injury. And in that vein, by looking at the recovery in functional asymmetry, it seemed like it took 1.9 years approximately for functional asymmetry to reach values that were comparable to some of the other data that we've collected on non-injured elite ski racers. So this ties back into that question that's in the literature these days, which is it really a 4-month return to sport? Is it 12 months? Or is it something that extends much far beyond that to ensure that athletes are progressing well as they come back into a high-risk activity? So I think to kind of conclude, the first major take-home message is I think that the ACL injury is probably just, the ACL tear itself is probably just one small piece of the puzzle. There's other things going on with these injuries that are obviously contributing factors to recovery. And that's the hunch of a lot of the surgeons, that they feel that especially the bony injuries are the big things that that need to be accounted for in recovering an athlete after an ACL injury. Also, it seems clear that ACL reconstructed skiers will have neuromuscular deficits that are going to persist. So once they get cleared to go back onto snow, it's likely that they're going to have something there that is a deficit in terms of from a neuromuscular standpoint. So this ties in the importance of having, evidence-based return to sport screening protocols, and that this is just in one small piece of the puzzle or one small step working towards that, which is trying to develop tests that we could use to evaluate skiers as they come back after ACL injury. And the reason I think that's important is that there is the potential for not only a re-injury in that short time that they're coming back and trying to get back up to their top performance level, but there's big concerns around skier safety. It's a high-risk sport, and we also know that there's probably going to be an impact on them 10 years down the road. So I think to address these issues, the real critical step is to be able to employ some of these tests in a more prospective manner, where you've got a cohort of athletes that you can follow along to really evaluate what is the implications of an ACL injury for this athlete population. So with that, I just wanted to take a moment to acknowledge different individuals that have helped me with the research. Obviously, Dr. Herzog and others, and the Herzog group, which the great expertise and people in there that have helped me work through some of these questions that I've had. So I want to acknowledge them, and I also want to take a moment to thank you for your time, and thank you for listening.
So it's really great that you were able to look at the surgical records and medical records of a lot of these skiers. This is a really interesting cohort to look at. So there's some good evidence in animal models of trauma that if you give them a lot of anti-inflammatory really quickly within the time of injury, that it can actually prevent a lot of the cartilage damage. So I'm curious if you were able to see any relationships, even allegorically, of how much anti-inflammatories were given or used, and if that led to a better outcomes for some of the skiers that you looked at.
I don't have any concrete even hunch on that. It's one of the big gray areas is what happens after surgery. Even though they're in this sport where they've got access to physiotherapists and medical teams, it's something that is not well controlled. I'm just talking now even from a rehabilitative sense. But I couldn't even begin to speculate. I know that they have pain management early on after surgery, but I'm assuming this is at the time of the actual ACL injury itself, right? So yeah, it's interesting, really interesting. Yeah.
So you talked a lot about the semitendinosus graft and how that's going to modify the hamstring strength, of course.
Can you speak up?
The semitendinosus graft is going to decrease the hamstring function. But you did have a few skiers that got allografts, so they would have had an intact hamstring.
Yes.
Afterwards, were they able to recover their symmetry faster or better?
Yeah, I mean, it doesn't seem from a functional asymmetry standpoint in jumping. I don't have any indication that there was really any sort of advantage to that. Where we definitely see an advantage is obviously in their hamstring strength. I mean, the hamstring strength of after a semitendinosus autograft, where the patient feels the weakness is really in deep angles of knee flexion. And it's amazing how even 2-3 years after, they still struggle in that deep range of knee flexion to have strength. So that's a big difference between the procedure. And just as an aside, I think one of the reasons that they've opted towards hamstring tendon versus maybe some of the other options is, first of all, the allograft, the failure rate's higher. With patellar tendon autograft, the bone patellar tendon bone autograft, the big challenge is that that extensor mechanism is they just get really cranky knees. So that's been the method of choice, and really functional asymmetry wise, I haven't noticed anything, but for sure hamstring strength is much improved.
For the allografts, so in the specific population of these elite skiers, though, that's it. The general population for sure, the allografts fail way more often and way earlier than the hamstring tendon. But maybe with these elite athletes where they have such strong hamstrings and it's actually a modifiable factor, has anyone done like a risk-benefit analysis of maybe an allograft over a hamstring tendon?
No, not at all. Not at all, and that's a.
You wouldn't additionally compromise their legs.
I know.
Right, anywhere.
Yeah. They haven't done anything specifically around ski racers, and certainly I think that's one of the areas that could be very exciting in terms of a future research project is, factoring that whole choice of surgical procedure into the actual recovery and long-term outcome. Yeah, so they just started kind of going off the data from the general population that shows a higher failure rate. So that's a good question though.
Yeah, you've done a good job of documenting the functional deficit over an extended period of time. Have you got any sense of why that was, what it is that's different about the reconstructed leg versus the other one that would make the performance different? Is it a sense of instability? Is it muscle degenerated? You know what might be causing that performance difference between the legs?
It really, on some levels, does come down to a very individual basis. You've got some athletes that are absolutely fear of re-injury. So they just unload the joint, sort of a central decision-making type thing where they actually, consciously avoid loading it, which is one problem that we see. The second component that I think is, again, this is anecdotally, but seems very, very important is the bony injury. When they get pain, and the bony injuries really cause quite a bit of pain for them, especially when they have one of the injuries that is really prominent in ski racing, especially when they land in that back-weighted position, is that tibia drives forward and they patella bangs into the trochlea, and they end up with sort of patella injuries and trochlear injuries. That's very, very painful in any sort of squatting, jumping, and I think that's a big contributor as well for some of these athletes, that when they have that type of an injury, they have much higher asymmetries. We had one skier who had a very, what I'm going to say, a clean ACL. He cleaved it. So his injury was a hyperextended knee, and he literally just cleaved, like according to the surgeon, cleaved the ACL, or had very minimal extra injury. Within 12 months, you wouldn't have been able to really differentiate him from a non-injured skier in terms of his asymmetries. So to me, I think that's a very important rock to look under, is the impact of these secondary injuries. So that, and then obviously there's just really the neuromuscular control side of it as well that I think is another interesting aspect, which is hamstring guarding, especially in that terminal end of knee extension where there's probably still some inherent instability, and they just have developed a strategy locking down with hamstrings to really safeguard that knee joint, and as a result, that contributes to some of their asymmetries that we see. So, yeah.
How do they get the is the short angle relationship or the velocity relationships they are tested before they decide if an application goes back or not. Because these will tell exactly how the muscles are, what the muscles are doing. But also you can see if the muscle, if there is deficit, if the muscles they have atrophy, or it's just an activation problem. You can look at variation. So things like basic mechanical properties and activation properties.
Yeah, I completely agree with that, and we've started with our profiling to include multiple angles on looking at the recovery. So we do hamstring knee flexor strength curves. We've got an isometric leg press, so we can look at sort of a strength curve for versus knee angle of for sort of leg extension, full leg extension. I think that, because if you're speaking to the point that there's so many different levels at which asymmetries can creep in, the DEXA scanning gives us a sense of that muscle mass asymmetry, and really from a prescriptive standpoint, really what you want to know is, where do I want to focus the training program or the rehabilitation program to best address the deficit? So I think that further diagnostic into, basic muscle properties, I think is a really important aspect of this. Absolutely.
Two questions. One is, are there differences between male and females in the deficits and the recovery from deficits?
It's a huge limitation of this study is that we are unable to really tease out the sex differences just due to the fact that we have smaller numbers of subjects. So I think that's the first part. Is I think that's a really, moving forward, a limitation. It's something it's key for us to look at, because we do know there's differences between males and females. A couple of interesting things about ski racing is at the highest level, there's actually no difference in ACL injury rates between males and female elite ski racers, which people have speculated is the fact that maybe that the women are just as strong as the men at that highest level, whereas a lot of the deficits in young female basketball players or soccer players, maybe there's issues there with just sort of development. So that's one potential. Or that these high energy injury mechanisms just override those sex-related differences that you see. So we weren't able to see anything anecdotally where I could see a difference between a male or a female. One thing that I found was interesting in that second study where we looked at quadricep hamstring strength in males and females, we normalized to body mass. And at that point, we actually found no difference between males and females in terms of their uninjured, non-injured elite ski racers. There was no difference between their quadricep and hamstring strength. But it's a very important part, I think, moving forward, especially at the young level.
The second question is, when a surgeon puts in the graft, it's pretty strong. And over time, you can stretch out and get vascularized and maybe partially reinnervated, but it stretches out. So when you put it in, it's actually a dynamic going forward to reaching a steady state at some time.
Mm-hmm.
So do you think that plays a role in persistence of the asymmetry or the deficit?
Oh yeah, absolutely. And one of the big eye openers through this process is he was able to spend quite a bit of time up with surgeons and watching them operate and looking at the variables of where they place the tunnel and the angle and how they get it into the sweet spot, right? But it's amazing that all of those factors strongly seem to play in. Even if in the early stages of rehab, if the athlete's a little aggressive and actually stretches it out, or at that 3-month mark, they actually start to, probably more like 8-week mark, they really start to feel good. But the ligament's actually in its weakest state just around, or the graft at that point in time. And so, there's that danger where you don't feel the pain anymore. So and all of those factors very much impact. I worked with a competitive martial artist who, on his every single ACL, I would watch on his Facebook that he would be on the night that he got his surgery out on his crutches, walking around, and it was no wonder that he had retore that knee 4 or 5 times in a row. And I'm sure it was just because of that mismanagement of those factors. Yeah. Chris?
I was curious, thinking back to the hamstring graft situation, And considering these are elite alpine ski racers that have huge hamstrings, do you think that these are going to become more pronounced in a population that isn't elite to a regular civilian population? Especially considering how much sometimes they have to take of the tendon and the muscle, and how that could affect maybe permanent changes to their neuromuscular deficits by removing some of that AFib feedback?
Yeah, I mean, what's interesting is that what I've observed is that there's a lot of factors that go into the decision-making process. It seems like when a surgeon's deciding what way are they going to go, and I think that there are factors like time. Which one are they better at? Which one can they more quickly get done? I think there's factors like which one do they feel more comfortable doing, but they also sort of bring in factors like alignment and whether or not if you've got somebody who's a bit valgus, whether you should destabilize the medial musculature by removing the semitendinous, so they might opt for something else. That whole area of the procedure, what gets done at the time of surgery, whether the meniscus is resected or repaired, they use semitendinosis or patellar tendon or allograft. I think there are a bunch of variables there right now that are really big question marks for me moving forward about interesting questions, because I don't know how surgeons are going to, I don't know how much good data there is around those factors in terms of decision-making process.
With the surgeons that you've interacted with and talked to, does anyone ever think about using something else, like the plantaris, for example? It's a harvester. It's considered a harvester tendon for lots of other types of surgeries. Is there a reason why we ignore it right there at the knee and could provide a potential graft, you think, without having to take such a critical stabilizer with the knee and hamstring?
Yeah, I don't have a good answer for how that works. I know that there's been more discussion inside our Alpine team about using quadricep tendon.
Oh, really?
Yep, and so they've done a few. Through this whole process, one of our only ACL injuries after I started this endeavor was he had a quadricep tendon repair, and that seems to be the new buzz. Is potentially the new one of the new ones that they want to explore. I think a lot of it comes down to surgical sites and prep. I'm guessing. I would love to have one of the surgeons here to better speak, because I'm just totally speculating. But it seems like a lot is around the efficiency of the room, the efficiency of the draping, the sterile site, and how you can just minimize the number of cuts you have to do to be able to get what you need done. And so I think those seem to be some of the drivers.
Matt, could you, this is going to sound maybe a bit draconian, but you're having trouble with this imbalance, with this asymmetry following the surgery. Rather than, it looks fairly ineffective to try and reduce the symmetry by making the weaker leg or the surgeon stronger. Could you consider just Botoxing? It's nominally reversible. So instead of trying to make this, I'm wondering if that's a feasible option.
Yeah, in general, I have to say that I would rather have a strong but asymmetrical person than a weak and symmetrical athlete. So we have some athletes that, are pretty asymmetrical, but both legs are pretty strong. So it doesn't seem to be much of an issue. But where our current line of thinking would be around, that sort of the weaker athlete might be at that higher risk. But I think, this kind of speaks to the whole, so what? So they're more asymmetrical. What does that mean? And that's one of the things I would really like to, look at moving forward is, is there a relationship between asymmetry and the pattern of injury? And, at certain asymmetry levels, you're okay. But at other asymmetry levels, that becomes really problematic for return to sport, and you need to give them a little more time. So it kind of speaks to that bigger question about how does that asymmetry play into recovery and function afterwards.
I have two questions, one a specific one and one a philosophical one. specific one is how, could you explain again how in the counter movement jump you determine the phases?
Yeah. So we very simply, we solve for acceleration. Very well, first of all, very carefully define the start and the end point of the jump so that we capture right at the beginning and obviously to the point of takeoff.
The velocity, when the velocity is lowest, then you have the end of the first phase.
Yeah.
How is the end of the second phase defined?
The end of the second phase, so the concentric phase, is by the instant where the ground reaction force drops below 0 as they toe off. So we integrate right up until that point.
Ground reaction force?
Right at the point where the vertical ground reaction force drops down below 0. So right at the point of literally just toe off as they come up off the plates. So we integrate from...
Can you go to the slide?
Yeah.
So on the left-hand side, you have the yellow phase starts at the lowest velocity.
Yeah. Right at the where velocity is at its minimum. And then we take...
There's a maximum, the downwards velocity is at a maximum.
Yes. And then so in this case...
about that, whether that makes sense or not. But what is the end of the yellow phase?
Yeah, well, and I apologize, it looks like the bars are a little bit smudged or like, it's a different screen size. So we take it right to the point of 0 velocity. So basically that phase where the velocity is increasing, but it's still negative. So it's
that's the deepest point.
Yeah, this is
the low center of mass is the lowest point.
Mm-hmm.
And then the end of the green phase
is basically right here, right at the point of takeoff.
Oh, it's just...
Yeah, it's just kind of smudged, like the screen size.
Okay, then the more philosophical one. You know, I always think that the ACL doesn't have a function to provide force to control movement. It's much too weak. I mean, little shocks and ruptures. So I think that the ACL has much more a function of knowing where you are and giving you some information about position. Now, when you have an artificial ACL, you don't have that function anymore. So I think that the whole project should have a part where you address that aspect, because it's not only a question of force, it's a question of control.
Yeah.
And that control has one input less.
Yeah.
Did you think about that? Or?
I totally agree, and I did think about it, and I do think about it currently moving forward on a practical standpoint. I had a very interesting chat with somebody at a ski conference recently, where if you look at ski racing and you look at the return to sport after ACL injury, it's amazing that there's a very high percentage of them that get back to high level skiing after their ACL reconstruction. And you compare that with other sports like, let's say, soccer, where 65% might make it back to their pre-injury performance level after an ACL injury. So it seems like ski racers have this incredible capacity to get back. But then in this conversation, the conversation went more around, well, do you really need the ACL to ski? I mean, you're kind of in a position where it's a lot of kind of frontal plane loading. It's not like a cutting and pivoting sport where, I've got to make moves with lots of twists, right? And so as the question kind of comes down, it seems to me, and that's why I said at the end, I think this ACL tear is just one small part of the story. I think really the big thing for a ski racer is if they have a high energy injury mechanism and they bang the femur off the tibia or they jam the bones together and they end up with these very bad bony injuries, that those will likely be the things that will be the end of the career And that's where, you know, they've got pain inhibition and all these other factors. The proprioceptive loss seems to be one of the key things that we need to restore, because you're absolutely right. They lose the proprioceptive component, which is just an angle I didn't choose to look at with my research, but I know it's of a vital importance for these athletes and for anybody coming back after an ACL injury.
The last question is, does Canadian Ski Association use your method, or
It's
any ski association?
It's becoming more and more a part of the practice now. And when I say the practice, I mean the procedure. So what I've found is that as I share my research with you know, surgeons and physiotherapists, and even to an extent some coaches, they're more and more starting to see the value in at least measuring something around the athlete after their injury. I would say that we're 75% there in alpine ski racing.
I mean, you quantify about 75% of the top athletes, their measurements.
In alpine ski racing in Canada, we'll test 100% of the athletes. Whether the data gets used is a whole other question. So where the challenge is, you know, and this is how it often goes, is that the athlete will go visit the surgeon will check the handiwork and say, yeah, I think you're good to go back on snow. So we've had to change the discussion to say, okay, now let's use this data that we're collecting as part of the conversation to really, you know, guide the process. And I would say in alpine ski racing, where within Canada, all the athletes are being tested. Whether or not the data is being used effectively in decision making is a whole other question. And I would say 75% of the time we're doing a good job. It gets harder and harder and harder as the athlete gets off out of our wing and back into a training environment on snow. It gets progressively harder to evaluate them. I think another big area that would be important for this is being able to get on snow metrics, so that you can look at them in that transition where they're now on snow and training on a glacier somewhere, where you could actually look at some asymmetries as they're skiing. Because we can get them well in our environment. It's really tough when we get them sort of, and they're now off on their own with their coach.
The measurement, the insoles for on ski measurements.
Mm-hmm. Yeah, well, I mean, Ski
Canada.
Yeah, they do, but the athlete or the skiers don't like putting them in their ski boots because they're too, yeah, they say it's too tight for their feet, which doesn't make any sense. But maybe GPS data. I know that there's been recently, it's not my area. I've got to learn more about GPS, but I know that they've been estimating, you know, kinetic energy using GPS or using inertial measurement units to look at kinematics, which seems pretty interesting as a possibility. And maybe that's less of a problem than having to get an insert into a boot or try and build a force plate into a binding. I think it's an important area. We lose them at that point. And it's I think one of the things through this research that the way I've changed looking at it is I really see it as 24 months minimum. Like that's how long the conversation has to go on with an ACL injured athlete to make sure that they're kind of graduating back into, you know, cleared to go back. So for me, it's, you know, keeping tabs on those athletes through that high risk, that vulnerable period for re-injury to I think that's a really important future step for what I'm looking at.
So when you say they go back to training, do they go back to training like they've always gone back to training, or are there any training approaches that would help the ACL reconstructed athlete get back better? I guess what I'm saying is, are there any efforts to tailor training methods to allow the ACL reconstructed skier to actually recover better rather than just put them back in the pack?
That's precisely where within Alpine, the Canadian Alpine organization, we've gone. So now how it looks is at that point in time where the athlete's been given the clearance to get back, in combination with our asymmetry testing, in combination with what the physiotherapist has been seeing, in combination with what our mental performance team is seeing in terms of the psychological readiness, we're making a determination that's actually guided by one of our physiotherapists who happens to be an ex-ski racer herself. And she programs that first camp, how many days in a row before abreast, what type of skiing. And in some circumstances, she's actually started going on the hill with the athlete to do on-snow physiotherapy, to transfer what we're trying to do in the rehabilitation sort of sterile environment of a clinic and bringing it out onto the, on-snow environment, because that to me is the key there, because you're really getting that continuity and that transfer. Where I think we miss out is, we still don't have good monitoring once they're on a glacier. We don't, maybe we can do some single leg jumping, compare left to right, or, I monitor, maybe monitor training loads or wellness and, sort of generally looking at their fatigue state, but it's quite blunt in terms of our capacity to see what's going on.
I'm just wondering if, since you've been doing this for a while now, have you been able to address these asymmetries in your ACL reconstructed to bring them back more towards it?
How?
Have you been able
to? Have I been able to? The cases where you have a situation with a ski racer who has not had bony injury, we have been able to. And I was actually debating whether I should put this in the presentation, and I opted not to just by sake of time. But I actually have on our one skier pre-injury and post-injury data where you can see his recovery in functional asymmetry. And the recovery in this eccentric deceleration phase in this functional asymmetry is nearly linear as he starts at 3.5 months when we test him first, and then 4 months, and then 5 months, and then 6 months back into a pre-injury value. So in those situations, we have been able to. Again, where the hardest situations we've had are the athletes who end up with a bony injury and have pain. And in those situations, I try to incorporate a lot of different things on basic muscle mechanics. So force length relationship, training them above and below the painful range to try and, to develop, some sort of active muscular support through ranges of motion potentially where they've got inhibition and pain. So that's the really tough one. But with our simple ACLs and maybe an MCL, like the guy that had his injury was an ACL MCL, no bony injury, but he's recovered very nicely. So I mean, he's barely out of the woods though in some ways, right? Yeah. So 14 months or so. I know he's got a ways to go before he's kind of out of the clear, but he doesn't think that. He's just racing and doing his thing. Yeah.
This would be really hard to measure, but do you feel that the addition of this metric or this expanded conversation in return to snow actually helps with the athlete's confidence in not being as worried about re-injury? Or do you think that that could be a component in this whole process?
Got 2 experiences to reflect on that. The first is dealing with an athlete where on the monthly basis where we would assess him coming back, in his rehab, where I could sit down and say, hey, you've done a great job. Your asymmetries come from 25% and you're now down to 15. And his reflection, not told to me because I didn't ask him, it was somebody else, was he found that motivating to say, oh yeah, I am making progress, I am getting better. So from his perspective, I think that he might say that, in those phases, it was very helpful to have that and motivating. On the flip side, I had a conversation with a coach where now this athlete was back on snow, and the coach, basically said, stop asking how he's doing because you guys are going to make him doubt himself. So, and touche, I guess there is a part of just blind confidence that you're good to go, right, is important versus, are you okay now? Are you okay now? Are you okay now? Like that can be problematic for people, as they're just trying to move on and get on to life. So it's a balance, I think, ultimately, I think it can be very valuable providing it's not too much and providing it's delivered the right way. It's not a panic mode. Oh my gosh, it's always sort of delivered to an athlete in a way that, is reasonable about what we're going to do about it. So it's really my only example. I've used it a lot as a practitioner, prior to delving into my PhD, where with the really complicated situations where you're, just trying to figure out how am I going to get this athlete back? Using this as a diagnostic tool to figure out if my programs or the rehabilitation plan, if it's actually making an impact. So I think it can be valuable there too, just qualitatively. Yeah.
Did you ever look at any of the other dimensions of the force plate, or did you only have access to the vertical ground reaction force for your asymmetry index?
We only had access to the vertical.
Okay.
Yeah. And so, I guess that's the qualification about this. I didn't, how do I say this? I didn't approach this project as a biomechanist. I approached this project as trying to have something that could be easily implemented in a daily training environment, and that we could obtain information without too much work. Even like you could think about doing kinematics analysis here would be very interesting. The challenge I have is that, I might have, 5 or 10 minutes to assess somebody on a Monday. I just don't have time to do the bigger protocols, right? So the limitation here was that we only looked at the vertical ground reaction force, and we used it simply because this test was relatively easy to administer. We actually have a pair of portable force plates too that we can tote around the world. You can just set them up anywhere. We haven't been doing that because we don't have anybody who could do the testing on the road. But so from a let's say practical standpoint, that's the decision making around why we chose what we did. But from a research standpoint, I think there's also a lot of questions that stem off into the areas that you're speaking about that could be really interesting to better look at, some of the deficits that these athletes might have.
So Matt, I'm kind of interested in this 2-year kind of time point that you've created at this point, and I guess when I looked at your graph looking at the asymmetry over time, it certainly decreases back down towards 0 after 2 years. But then what I noticed is, right, the standard deviation is very tight at that point. And the standard deviation really blows up and continues to get larger and larger and larger as you go to that 4,000 day mark. And I think, first off, that points to the fact that, it's never really ending, right? Like the rehabilitation process for these people should really be continuously ongoing. They probably need to be continuously monitored. But I guess the real question is what causes that variability that you see later on? Is it these people who have chondral deficits? Is it the people who have meniscal injuries? Or is it the people who just kind of, decide, oh, I'm back at, I feel pretty good, and so I'm going to stop really doing these extra rehab exercises. And then, some of them see an increase in their variability or in the asymmetry, and some of them don't.
Well, I think one important thing to mention is that there are some big limitations in the data, and the way I framed it is, this was an exploratory study where we happen to have ACL reconstructed skiers at various time points. But one of the challenges is that, a few people shape the data at different points in time. So I think that might be one reason why the confidence interval kind of spreads like that as time goes on with the data that I have. Practically speaking, when you start, and this is the danger of reading into case examples and case situations, is it seems like, anyone who's around for that length of time, by the time they're 12 years post, unless they've done the nice cleave of the ACL, they're going back in for more stuff. Like they're having more procedures and more issues and more surgeries. I mean, it's really seems to be the case for a lot of these athletes. Like we've got athletes with, we're talking one person with 15 to 20 knee surgeries over his career, and that's somebody who's been in the game a long time, right? But his knees are horrible. So that's, I think, to your point, limitations with the data, but really I do think my mind goes the same way. Is this is a long-term thing, and I think ultimately it's going to be something that this athlete's going to likely have to contend with on some level for a career and maybe a lifetime. And some of these ones who go on into life afterwards and can't play with their kids because their knees are so beat up.
And I guess to follow that up, it's kind of, maybe in such a dynamic sport, maybe the counter movement jump where, isn't, I don't know, it seems like it's useful and it's interesting that you're measuring, I guess kind of like power output, right, is what people use the counter movement jump for. But maybe you'd be interested in more of like a dynamic activity, like some kind of plyometric routine where you can look at ground contact time or something, right? So you can look at kind of a duration over time to see, you know, is there a difference between both legs? Does someone, you know, does that change? And maybe that might be a better predictor of, or, you know, how the rehabilitation process is going.
No,
and I mean, I don't know, in skiing it seems like, especially when you're turning, that you're probably really loading one limb, right?
Mm-hmm.
And kind of, you're probably certainly loading both limbs, but one seems to be really driving those turns, right?
Yeah.
And so I think, again, that, you know, something more that might be single limb might provide you with a better idea of what's happening as they fatigue.
Yeah, no, I agree. And you know, I think that's, again, just sort of talking about some ideas for future work. I mean, it's right along those lines of, you know, I think this is I feel like it was a nice start to find a practical tool that could be used in the daily training environment. And, you know, within 5 minutes, you could capture asymmetry of an athlete. But, you know, moving forward, having field tests, multi-direction ability, which would get at the proprioceptive ability that Dr. Nig was talking about. I think there's some real merit to that, and could be very interesting. And I think any sort of prospective study is probably going to have to take that broader approach to having a few different tools, tests, to evaluate the skiers or evaluate the subjects as they go forward.
You said that for your healthy athletes, that most of them have fairly equal strength between the two legs. Would you say that at that level, people still have a preferred leg?
With the ski racers,
yeah.
We asked the question in our questionnaire. When we asked this also of our non-injured skiers, but which leg do you prefer to kick a soccer ball with? Which is, I know, not the most sensitive measure for limb dominance, but most of them would say a right or a left. We have seen like a few that would be bilateral. They'd say either one would be good. And my observation has been that there seems to be less limb laterality preference in this group comparatively to some others, but I don't know. I think it'd be an interesting area too. Like even looking prospectively, is that especially with young athletes, is there's a research paper out there that's shown that, and this was just leg injuries, it wasn't knee injuries, but that there seemed to be one side that got hurt more than the other in a young group of ski racers. So I think it's a good area for looking at.
Yeah, one thing that we observed in the POA study, where they're not elite athletes, but they're kind of 3 to 10 years out from the injury, fairly active, that there is some sort of interaction between whether the injured leg was the preferred leg or the non-preferred leg, and that would change how asymmetric they would be after 3 or 10 years. So if you kind of have a preferred leg and then you injure that one, it won't be as bad as if you injure the non-preferred, maybe less able one.
Right.
So that could maybe explain. I saw there was quite a big spread in your asymmetry index for the injured group.
Yeah.
Maybe that could somehow explain some of that variance.
Yeah, maybe. Yeah. Oh, that's interesting.
Jared, last question. You mentioned earlier that you'd rather a very strong athlete with a high asymmetry index compared to someone who's weaker but has maybe the same, like, did I understand that correctly? It seems to be contrary to what everything you said.
I know.
So could you maybe clarify that, or is absolute strength or relative strength or absolute strength between the limbs sort of a pull factor or something to account for?
And this is just based on anecdotally watching these athletes. They are in such a skill sport, and it's really at the top level. These they're just highly skilled. And where I think they get into trouble is when they have unexpected perturbations or eccentric loads that come from the snow or come from, whatever's going on in their environment. And really, for that limb to be able to dissipate that external load, I think they require a certain amount of strength. And so, whereas a weak athlete, I think, is vulnerable in ski racing. Now, because I don't think the asymmetry thing would play as much in maybe some other sports. But in ski racing, I really believe athletes that are really nice skiers but not strong are in a rough place, because there are just these unexpected high force, high energy movements that come out of nowhere. and you got to be strong, and you got to be able to handle that. So that's why I made that comment, which I know it doesn't make sense based on the presentation, but
Thanks very much.
yep, thank you.